So, Dr. Porter, welcome to the Cutting Edge. We're here at SAGES 2025. Obviously, your specialty is along the lines of common bile duct explorations, and historically, we've been passing that on to our gastroenterology colleagues, a lot of ERCPs, but you are now on the forefront of moving this more into a minimally invasive robotic approach.
This is not new to the general surgeon. We were doing this open 100 years ago. It was really when there was the transition in the 80s to lap chole. The technology for the minimally invasive bile duct exploration was really rudimentary at that time. And so something that used to be a disease process that was really just managed by the surgeon intraoperatively suddenly became this 2 to 3 multi-procedural event, because ERCP had come around 15 years earlier and the technology was just so much more advanced at the time. That in 2013, only 3% of bile duct explorations were done laparoscopically. And so the question is, where does that bring us now in 2025? That now the technology has caught up. The instruments are flexible. We have wire interventions, balloon interventions. I always say if you can do a central line, you could probably do a bile duct exploration. Not everywhere is going to have access to ERCP. I worked at a hospital. Even though we're a busy level 1 trauma center, we're community and we have intermittent ERCP access. And so suddenly this problem where in training I didn't think twice about it, suddenly patients were being transferred out. They were waiting a week in the hospital. They were having multiple procedures for something that I knew I could do in a single stage surgery first approach. But I personally was switching to a full practice robotic. And at that time, there was nothing out there for educational material on how to execute this, at least in a transcystic fashion. I think a lot of HPB specialists will open the common bile duct or do a transcholedochotomy. But the minimally invasive, truly safe, reliable through the cystic duct technique wasn't out there. So shameless plug, that's what led to me figuring out and then actually starting a YouTube channel with educational materials through the help and support of SAGES with Dr. Santos. And this year, I was invited to be a co-chair with him and actually running for the first time the robotic track.
Where have you seen the most pushback in this field?
In terms of executing it or in terms of teaching it?
Either case, we'll say the antis or the not so happy about this.
The non-believers?
Yeah, what are the non-believers
who are not taking the common bile duct back?
Yes.
Taking it back. The common theme is GI going to be upset? Right. Got their input. It actually was interesting to find out that they don't actually want some of these consults, because over 70% of stones that are diagnosed or predicted, let's say, because we don't actually know if they're diagnosed, that's a whole nother conversation I can go on for days about, but predicted stones, you go to an ERCP before surgery, 70% either they're not there or it's something very minor that we could have treated during an IOC. That's not high RVU production for a GI specialist, right? So instead, it's incurring incredibly high risk to a patient, another anesthetic event, doing interventions that can lead to major complications and death. It's not benign to get an ERCP. I think the endoscopists, because of that huge shift for the last 30 years, it kind of went too far, where they were getting all these consults that were unnecessary. It's a lot of burden on them to do the consult. GI has to go to the ER, see the patient, write a note, follow them. That's a lot of throughput and work. I took that burden off of them. And I think that's where I pulled them in and kind of got that argument to go away, because now we're a bile duct service. You consult my team surgery first. We typically admit you, and then we decide where you're more appropriate to go, because not every patient should have a common bile duct exploration. Right? I think another common misconception is that it might be unsafe, or perhaps because you're not an HPB specialist, that this is maybe not appropriate to be doing for patients. I would argue against that. I'm an acute care trauma surgeon. I am not HPB specifically trained. I feel I had good training, but the way that we do this, it's transcystic. It's all over a wire. It's all Seldinger technique. Again, if you can do a central line, you can probably do what we do. Pay attention to your own outcomes. You come to conferences, you join webinars, and you stay up to date on the possible risks and things to look out for. You can be very safe and execute this. But I don't consider myself to be some savant surgeon. I just am meticulous about a step up in risk to the patient with effectiveness. And so I have an algorithm where it's fluoroscopy first and then only cholecystoscopy if that doesn't work. We push all stones forward. We have 95% success and almost no complications.
I find it interesting. It's always that debate, like you're going into HPB in this case, but even when I was younger, I'm not that old. We were doing open common duct exploration. General surgeons were doing that, and that's
no one thought twice.
Yeah, nobody. I mean, it was because I find it a little odd to now say that transcystic is this.
It's fascinating that now there's an argument for it. I think that happened too. If you look at a different field, like TAVRs, right? You have a lot of non-cardiac surgeons doing perforate the myocardium, and now they have pericardial effusion, and they need an emergent pericardial window. You have to consult someone else.
Yeah.
But I think that's part of innovation. That's part of giving access to hundreds of thousands, if not millions of patients to the benefits of minimally invasive are going to come with some price tags, and some of that is being really thoughtful and safe and knowing your limitations.
Quick as you are, it's well deserved, obviously. So we truly appreciate your time.
Thank you.
And once again, thank you for coming to the Cutting Edge. I hope you enjoy the rest of your time here at SAGES, and we look forward to hearing from you in the future.
Well, thank you.
Thank you.
Okay.
Thank